Hello everyone, now I'll discuss question of neurology. So we have a 64-year-old man brought to emergency with sudden onset of painless lower extremity weakness. Well, he was in the swimming pool and suddenly he felt legs become weak and he felt the leg had lost all strength and he was unable to move them. However, he struggled out of the pool, called emergency medical service and was rushed to the hospital. He had no trauma, no loss of consciousness or visual or speech problem. Well, he was in the swimming pool, don't forget. Okay, thank God he did not drowned. He could come out of the swimming pool, but at the moment he cannot pass urine also. In the case of type 2 diabetes, hypertension, osteoarthritis, long-standing back pain. Oh, this is something notable. Examination shows motor weakness in both legs, numbness from umbilicus to the sole of the feet. No sensation in the perianal area, rectal tone is absent, Foley's catheter and 800 ml of urine is collected. What is the best next step in the management of this patient? Well, the answer is surgical evaluation. That means we have to really first evaluate what is the reason, and most likely it is surgical cause. Perhaps the patient will be needing surgery later on. That's why the word they use is surgical evaluation. Let us see. Well, the patient presentation is worrisome for acute spinal cord compression. Spinal cord compression, why acute? He was doing swimming. Suddenly he found his legs are not working. Thankfully, he came out of the swimming pool. Can you think why he came out? Legs were weak. His arms were normal. That's why he struggled and came out of the swimming pool. That point should be noted, why and how he could come out of the swimming pool. Well, there is a loss of motor and sensory loss, especially in the both bilateral lower leg weakness is there. Absent rectal tone and urine retention. How do you show? Because there are 800 ml of urine came out when the Foley's catheter was passed. Well, spinal cord compression is characterized by injury to the following. Why this happen? The clinical feature what we got in the previous slide. Descending corticospinal tract involvement. That is motor fibers. And that lead to lower extremity weakness and loss of rectal tone also. Ascending spinothalamic tract involvement, and that lead to the end. It is spinal level is often two spinal cord segment below the level of lesion, and there is loss of sensation. Okay, that loss of especially pain, touch, temperature. Descending autonomic fiber in the reticulospinal tract, and that lead to urine retention, flaccid bladder, and bladder shock is there. Okay. Well, now a question for you. Stop the video, write down the answer. We are getting the patient with distended bladder. What is this known? What type of bladder is this known as? Stop the video, write down the answer in your copy. Well, the answer is autonomous bladder. It's a so-called lower motor neuron bladder. And the feature is distension with overflow. Okay. Well, now when we are talking about this case, patient has come with acute paraplegia. What are the other differential diagnoses? Well, we have one lesion so-called corus medullaris syndrome. It causes back pain and bladder rectal dysfunction, but weakness and sensory loss are less common. It's more of a bladder dysfunction. Okay. Now I have one more question for you. This Corus-Melleris syndrome, it is a very, very important differential diagnosis for which condition? Write down the answer, stop the video. Question again, it's a Corus-Melleris syndrome is a very important DD for which condition? Well, the answer is benign prostatic hypertrophy or so-called BHP. Both are same. Benign prostatic hypertrophy or benign hypertrophy of the prostate is the important DD for Corus-Melleris. Here also patient come with distension with overflow. Okay. But definitely weakness and sensory loss are not as, and moreover here in our case the weakness is up to umbilicus, sensory loss is there. This is not seen in Corus-Melleris. Cauda-equina syndrome, other important DD. Radicular pain is the classical feature, not the back pain. They more of a radicular pain. Lower extremity weakness, usually asymmetric. Sudden anesthesia is a classical finding. If you are getting in any question, you are getting sudden anesthesia, so most likely you are dealing with Cauda-equina syndrome. This is a golden line to remember. Bladder bowel dysfunction, but they are a very late feature. And this is due to involvement of sacral, but it's a very late feature or may not be there also. In contrast to Corus-Melleris, where bladder and bowel dysfunction are very early feature. Sensory level at the level of umbilicus definitely exclude Cauda-equina syndrome as well as Corus-Melleris. They do not cause sensory loss up to the umbilicus. So very comfortably we can rule out these two conditions. Well, as far as Cauda-equina syndrome, it is usually due to disc herniation or maybe some compression fracture or malignancy can lead to type of Cauda-equina syndrome. Now we learn that what are the problems that we have, and we presume that this is a case of acute cord compression is there, maybe due to some surgical reason is there. Why and how I'm going to discuss a little later on. So immediately you have to go for evaluation for surgery, and you have to go for MRI of the spine is the first, while awaiting for surgical consultation to go for spine MRI. Well, suppose we are suspecting some malignancy which is causing cord compression. Stop the video, write down the answer. For the first line treatment in suspected malignant compression in this case, that means there is spinal cord compression but by malignancy, the first thing you will do before you can avail surgical consultation? Well, the answer is high dose steroids are often used, especially for suspected malignant compression. Now let's look into other options. What complete bed rest for 24-hour physiotherapy and non-steroidal anti-inflammatory drug. This cord acute compression is there. Acute spinal cord compression is there. An urgent intervention is needed. Otherwise, it will have total disaster. We cannot. This is to be done, not the first appropriate. We have to first diagnose the condition, and if we are finding anything, something serious, then we have to do the surgical treatment immediately. Same thing, CT of head without contrast. Problem is in the spinal cord. Okay, so this is not indicated. This we indicated only in those where suspected some intracranial hemorrhage or stroke is there. And patient has bilateral lower extremity bowel dysfunction. They are more toward the spinal cord lesion rather than in the brain. So this is unlikely. So CT scan is not the right answer. Nerve conduction study, this we do for any peripheral nervous problem, especially like Guillain-Barré syndrome or any peripheral neuropathy. Okay, and it is not advisable in this case where we are strongly getting motor weakness with sensory with a definite level of up to umbilicus. This is not the first investigation. Golden line to remember: acute spinal cord compression can present with loss of motor and sensory function, loss of rectal tone, and urine retention. Management include emergency surgical consultation, neuroimaging, and possibly intravenous steroid should be given, especially if you are getting compression due to malignancy. Now, I must give you a summary of the spinal cord compression. This could maybe spinal injury, malignancy, or maybe infection, especially epidural abscess, are the usual causes of this problem. Gradually worsening severe local back pain, pain worse in the recumbent position or at night, early signs, symmetrical lower weakness, hypoactive or absent deep tendon reflexes, all these we are getting in this patient. Late sign, bilateral Babinski, decreased rectal sphincter tone, paraplegia with increased deep tendon reflexes will be happen if you are getting a type of even corticospinal tract are getting compressed. Then you are bound to get upper motor neuron features. We can get it. Okay. Point to be noted. Now you are definitely going to say, look, in the early stage we are getting loss of reflexes. In the late phase we are getting increased reflexes. What is the reason for that? Because in early stage patient is in spinal shock. And later on, when the spinal shock phase is over, then we get start. So in this case, we start getting feature of lower motor neuron palsy. But later on, when these patients start recovering, spinal cord recovering, we start getting feature of upper motor neuron feature, where we are getting increased deep tendon reflexes. But as the patient was in swimming pool, patient developed problem, patient is in spinal shock. And that's why deep tendon reflexes are diminished. But later on, we expect this to be increased. Management, urgent MRI, steroid, and neurosurgical and onco consultations should be done. Thank you very much.